We're all human. And it's important to know that doctors are people too. Doctors have emotions, they have passions in life and hobbies, and they enjoy participating as active members in the communities where they practice medicine. Doctors have families, friends, and relationships, while the latest in healthcare and the most current treatments for ailments will be topics on this Doctors Are People Too radio TV show. The focus will be in learning more about the interesting aspects in a physician's life and what they do away from the doctor's office or operating room table.
Good evening. My name is Patty Villa, and I am filling in for Dave DiPino tonight. Welcome to Doctors Are People Too, and tonight I have with me Dr. Neil Galindez from Florida Medical Center. Dr. Neil Galindez is a cardiothoracic surgeon. Thank you for being with us this evening.
Thank you, Patty, for inviting me.
And I also want to welcome your lovely daughter that's here with us tonight.
Thank you for inviting us.
Thank you. Let's start off with, this month is Heart Month, and I want to ask you, what should everybody know regarding matters of the heart?
Well, as you know, the American Heart Association has a big program that emphasizes on letting people know about the risk factors for heart disease. And as you mentioned, this month, February, is Heart Month. And the American Heart Association wants everybody to know that there are things that you should know about the risks that you have to develop this heart disease. So you can go and talk to your doctor and tell them, you know what, I know that I have either high blood pressure, that I'm overweight, that my cholesterol is high, and so on. So they can ask for a referral maybe to a cardiologist to be checked, to make sure that everything is in order for you to, that's the first step that you're going to take in order to take care of your own health.
And you and I spoke about what we wanted to talk about tonight, which is AFib, as well as heart failure. But before we get into that, I just wanted to give everybody the number. If you have a question and you want to call in and you want to talk to Dr. Galindez, please call 888-565-1470. The number again is 888-565-1470. What is AFib?
So in the realm of heart disease, there's several things that can affect the function of your heart. Okay, one of those are arrhythmias, and arrhythmias are just when your heart beats either too fast or too slow or irregularly. Okay, one of the most common arrhythmias is the one called atrial fibrillation. The heart has 4 chambers, 2 upper chambers and 2 bottom chambers. The upper chambers are the atrium. And when these chambers start beating abnormally, okay, that's when instead of having a normal contraction of the atrium that contributes to the cardiac cycle, then the atrium start just quivering or shaking. And that's what's called atrial fibrillation. When this happens, the coordination between the upper chambers and the lower chambers of the heart is lost. And that as a result, is going to bring some more problems. And in the long run, is going to create changes in the actual tissue of the heart that is going to create even more problems like heart failure.
And how common is AFib?
Here in the United States, we have approximately 3 to 6 million people that suffer from heart failure. And some of those are diagnosed, but many of those are not diagnosed yet. And that's the problem. One of the big dangers of atrial fibrillation is that it increases your risk of having a stroke. Just by having atrial fibrillation, increases your risk of having a stroke. And many people are walking with atrial fibrillation without knowing, because up to 40% of people will not know or feel any symptoms.
So what should a person do? Because, working at the hospital and walking around and talking to the different people in different departments, there's one woman that comes to mind that looked at me one day and said, I think that I have AFib. So how does a person know when they should really go see a cardiologist to find out what it is that they have?
One of the most common symptom for atrial fibrillation is fatigue. And atrial fibrillation, is most commonly found, and it develops over time with age also. So it is not uncommon to find patients that say, you know what, doctor, I've been feeling a little tired, and that fatigue is just getting worse and worse and worse. But they think this is part of their aging process, right? They're in their 50s, they're in their 60s or late 60s, early 70s, and they say, well, I always thought that this fatigue and tiredness was because I'm just, older and older. And if you make your annual checkups, an electrocardiogram should be part of it. And as doctors, or your doctor will know whether or not you're in atrial fibrillation just by taking an electrocardiogram. Some of the other symptoms that you might feel is palpitations, the feeling of something fluttering on your chest, or that your heart is beating too fast or too slow, or you can actually feel it on your chest, pumping on your chest. That's also very common. But patients can have just a little dizziness, okay? They can have even what we call syncope episodes, which is loss of consciousness momentarily. If any of those things happen, you should first call 911, go to a hospital, and if it's not an emergency, they should call your make an appointment with your doctor so they can get checked and get one of these electrocardiograms.
And I remember you and I have worked on a lot of stories together, and I remember mentioning to you a personal matter of mine, and you said you should definitely come see a cardiologist when I did the EKG, and we spoke about it. So what is it that you want the public to know about seeing a cardiologist?
It is important for patients to be referred to the specialist that will take the best care of that problem. If you have been diagnosed by, let's say, your primary care physician because they did an electrocardiogram and they saw atrial fibrillation, the next step is to be referred to a cardiologist, which is a specialist that only sees patients with cardiac problems, heart problems, right? So that's the best thing that you can do. You ask your primary care physician to be referred to a cardiologist, because the cardiologist will make a more extensive workup and see how much of a problem do you have. And if you do have atrial fibrillation, and you cannot be managed only with medications, then they might need to refer you with another specialist, in this case a cardiologist that specializes only on electrical rhythms of the heart, which is an electrophysiologist, to see what the best options for treatment would be.
And who are the people that are most at risk at getting AFib, would you say?
As I mentioned before, some people just with aging, that's one of the risks. That's a higher risk. The other population is overweight, people with problems of weight, body weight, people that develop sleep apnea, okay, and people that have some. In order for you to have atrial fibrillation, you have to have some sort of change in your muscle, in the actual muscle of the atrium in the heart. So people even with illnesses like heart failure, over time they stretch their chambers, their heart, and that creates scar tissue in the actual muscle of the heart, which we call fibrosis. And this tissue does not conduct electricity normally. So we know that the heart has a very, very predictive pathway, electrical pathway, and that's how the heart contracts, right? Because there's specialized cells in the heart that develop the capability of producing an electrical impulse. And this electrical impulse is going to go down a very definitive pathway or normal pathway to create the proper environment to develop a heart contraction, a normal heart contraction. But when there's scar tissue already in the heart, on the muscle, on the atrium, this scar tissue will interfere with the way that electrical impulse travels down from point A to point B where it should go, and starts creating other foci of abnormal electrical impulses. And that's what creates the problem. And the more it lingers, over time, the more the chambers enlarge, the more fibrous tissue the patient develops, and the harder the atrial fibrillation is to control.
And I want to mention to everyone out there that's watching us, that's listening to us, that Dr. Galindez is at Florida Medical Center, and he is going to be participating at an AFib symposium that's taking place Thursday, February 23rd. And he's going to be with Dr. Byer and Dr. Nairi, who he also works with, and I'm going to have him talk a little bit about that. And this event is taking place at 1801 Northeast 6th Street at 12 p.m. at Emma Lou Olson Civic Center. So you want to come hear about AFib, you want to come meet Dr. Galindez and Dr. Byer and Dr. Nairi, please come and meet us there at noon on February 23rd. One of the things I wanted to talk to you about is we sit in the cardiology meetings. And I have personally learned how all of you work together. And I wanted you to explain and talk a little bit about that so the public understands and the community understands that this is not only, they're not only getting the service of perhaps one doctor, they're getting the service of several doctors that all work in a cohesive manner.
Yes, we do have a very comprehensive service for heart disease, including the arrhythmia and the atrial fibrillation program that we have at Florida Medical Center. Is the surgeons, Dr. Byer and myself, and the electrophysiologists like Dr. Nayeri that take care of these patients. And what usually happens is if we get a referral for atrial fibrillation, usually it's going to be seen by one of the cardiologists that will refer that patient to the electrophysiologist. Once the electrophysiologist sees the patient, they determine what the best options of treatment they have, either medication or some of the least invasive procedures like catheter ablations or cardioversions. When the patient has atrial fibrillation, has had atrial fibrillation for a long time, that is called a persisting atrial fibrillation or long-standing persisting atrial fibrillation, then it's really hard, as I explained before, to control this kind of ailment. So what we need and what we have in Florida Medical Center, we have developed a program of the hybrid ablation program. And it's called hybrid because it takes two specialties. It takes the cardiac surgeons on one part and the electrophysiologists on the other part. And we both specialties work together to get a better ablation and better results in the long term for these patients. So it is a team of physicians. It's not only one physician that decides what to do or what's the best option for this patient, but we all see the patient and we determine what the best treatment plan should be.
And I also want the community to know that Florida Medical Center and Dr. Galindez, along with all the other doctors, are very involved in the community. And recently we had 50 students from an area high school, and Dr. Galindez was in surgery. He finished his surgery and rushed to the conference room to attend to the 50 high school students that were there. And they got quite the surprise because they were able to dissect a pig's heart. So I wanted you to talk a little bit about that experience and what that experience meant to you of being with those students.
Yes, thank you. The program was started and has been developed by Dr. Eric Byer, which is the director of the cardiac surgery program in FMC. And that day, there was a group of high school students that arrived at Florida Medical Center. And thanks to the Medtronic company that brought the actual tissue, the hearts, these are real pig hearts. They brought them to Florida Medical Center to show the students and to divide them into several tables and to show them kind of anatomy and physiology and just have a hands-on experience of what it is to what we do in the OR. And that was a great experience for them. There was an article.
It was amazing.
So they were. We asked them what they thought about the program, and they said that it was amazing because they've never done something like that before. And it was great to see these young minds trying to comprehend what we were telling them about the heart and actually have the specimen in their hands and being able to work on it. So it was a great experience. We'll keep doing that. That was a great experience for everyone.
Yeah, thank you for doing it. I felt the energy there, and the students were very excited. The staff was very excited, and I'm really looking forward to the next one. Moving along, you and I talked about last week. We wanted to talk about heart failure because a lot of people don't understand what goes into heart failure. So can you talk a little bit about that?
Yes, as I mentioned at the beginning of the program, heart disease is a realm and a spectrum of illnesses. One of those, and probably the most common one that everybody knows, is about coronary artery disease. And actually, if you look at the American Heart Association last update in January 2017, just last month, probably about 45 to 48% of heart disease is coronary artery disease. This is blockages in your arteries. There's a smaller part though, which is heart failure. And heart failure is just a decrease in function and the ability of your heart to effectively pump that blood all the way through all the vessels in the body. And when the heart, the muscle weakens and the function decreases, that's called heart failure. That can be caused by many things. One of the things it be caused by is coronary artery disease, having blockages on those arteries. And as surgeons and cardiologists, we have been really great and successful at treating these patients. The more patients we treat, the more survivors of ischemic heart disease or coronary artery disease we have. At the same time, because of those patients are surviving more and more, we have a growing population of patients with heart failure. Over time, some of these patients develop heart failure, that decrease on the function of the heart. So that's one of the causes. It could be caused by coronary artery disease, or it could be caused by infections like viral infections. Okay, and sometimes we don't know what's causing the decrease in the function, and we call it. We don't know if it's an infection. We don't know if it's a vascular problem. We don't know if it's some deposits of abnormal proteins in the muscle, but the function just decreases. Now, as I said, the population here in the United States of heart failure patients is increasing. The treatment for those patients, we start with risk modifications, trying to get the high blood pressure under control, try to get a good diet, low salt diet. If that doesn't work, then you escalate the treatments to use some medications, right? Up to the point where you just need diuretics. So this is the medications that get rid of some of the extra fluid that your body has, and your heart cannot pump effectively, and all the way to the last stages of heart failure, which is when the patient already needs something given IV in a daily basis. And these are medicines that are called inotropes. And when the patient is on those medications, just to try to get that heart to pump effectively, but the patient is dependent on those medications, then we are at the last stages of heart failure. The next step from that would be heart transplantation if the patient is a candidate for heart transplantation. And until a couple of years, there was no other option other than the patient going to a hospice if they were not eligible for a transplant. Now, we have created the technology to actually help the heart pump that blood flow again effectively throughout the body by the use of certain devices that we can implant. These are called ventricular assist devices. And these pumps, that's what it is. It's a pump that takes over the function of the heart by implanting this pump inside the heart in the left ventricle if the failure is from the left side, or in the right side if it's from the right ventricle. And this pumps the blood through the device into a small graft that is connected to the main vessel coming out of the heart, which is the aorta, which in turn will circulate the blood all around the body. It has been amazing because since the early, if you take a look at a graph of how many hearts do we have available for heart transplantation since the mid-90s, we haven't been able to do more than about 2,500 heart transplants a year. So the pool of hearts available for transplantation has been stagnant since then, since the 1990s, mid-1990s, okay? And as I mentioned before, the population that needs hearts is growing and growing and growing. So that's where this new technology of left or ventricular assist devices, it's so important and takes place because then now we're able to support all these patients that cannot either wait for a heart transplantation because they're so sick and they cannot wait on a waiting list, or they are not candidates for a heart transplantation, but they are candidates for a device like the ventricular assist devices, and they can go for many, many, many years after the device is implanted, while before the other option would be hospice.
Are you seeing a difference between men and women when it comes to heart disease?
There are subtle differences, but there are differences. If we talk about coronary artery disease and symptoms, things that you need to know, right? Everybody knows about the chest pain, chest pressure, shortness of breath, maybe a pain radiating to the neck, to the shoulders. In women, it's a little more common to have things like nausea, like the pain down the back or on the back, or pain on the jaw or the neck more than men. Why? We don't know why, but it's important for women there to know that if you start feeling a little short of breath, even without any chest pain, and you have any of these symptoms like nausea, vomiting, you get cool and clammy, start sweating, and a little discomfort on your shoulder or the jaw, as I said, even without any chest pain, then they should call probably 911 and get to the hospital to get checked. You never ever, if you're gonna drive, you don't drive yourself if you think you're having a heart event, right? Because
Right.
something can happen between your house or whatever the place might be and the hospital. Or you never ask anyone to drive you to the hospital. Just call 911, have the ambulance get there and take you to the hospital.
You know, this show is called Doctors Are People Too. So I want you to tell me how it is one of your weeks, because every time I talk to you, you're very busy. You're running around. I see you in the hospital. You're running from room to room, from place to place, from meeting and going to meetings. So tell us a little bit so the audience understands what it's like to be in your shoes.
We have a very, very dynamic service, and our group is comprised by 4 heart surgeons and a very talented group of what we call mid-levels, which is nurse practitioners and physician assistants, and of course all the staff in the hospital, including the nurses. My week starts, let's say, Monday morning. If I have a case, I'll be in the OR. Usually the cases last about, it all depends on what case it is, but an average about 2 to, let's say, 4 or 5 hours, okay? If there's a second case, then we go on with the second case. But if not, then it's time to go and check on patients on the hospital. The nature of the service is we have a lot of emergencies. So if they call any of us from any of the other hospitals, meaning the Ray Medical Center, Florida Medical Center, Palm Beach Gardens, even St. Mary's, then we have to go and assist and see what the problem is, what the emergency is, to see if the patient needs to be transferred back to any of the facilities where we have the heart program, and see if they need surgery emergently or not. And so we go and we evaluate the patient, and we make the proper planned treatments and decisions, and then we take it from there. And then, every once in a while, you're on call. So if there's emergencies at night, in the middle of the night, then you get called. You have to go see patients. Of course, you're always going to be, they're going to be calling you because of the patient that you operated on that morning. They need to follow up and close follow up. So you're always on the phone and thinking about patients or calling back to the hospital, making sure that everybody is doing well or rounding on your patients.
Okay, is that my next doctor or is that a caller? Next doctor? Okay. Why did you want to become a doctor?
I was always inclined towards the science of all my classes, towards natural science, and then it became medical science. Then I knew when I knew that I did want to be a doctor. I was involved in pre-hospital medical care first. I was a paramedic. Mm-hmm. I actually was working for a 911 service in South Texas for a while. And so I knew that medicine was what I wanted to do. When I applied to medicine, I knew that it was going to be something hands-on, like surgery, right? And so when I applied to medicine, I remember in my essay for the application, I said either I want to be a trauma surgeon or a heart surgeon. And throughout my medical school and going into my general surgery residency, I realized that I was just fascinated about how the heart works and how heart surgeons were able to actually stop the heart so they could work on the heart and still and start the heart again, and the patient will be fine. So that's where I decided that I wanted to be a heart surgeon. It was just fascinating to me to be able to stop the heart and work on the heart, and the patient will be okay.
And we're lucky to have you. We're very lucky to have you in our community.
Thank you.
And what is it that you do? You work so much, and I know you have 3 children in your family. What is it that you do for fun? Because that's what people want to know about you too.
So when I'm not working, we try to have a quality time. We try to, if we have like a weekend, we have to do like a short trip, and we like cooking. We like going to museums, and we try to be physically active as much as we can.
Okay. I want to mention to everybody that's watching and listening that Dr. Galindez is going to participate in an AFib symposium on Thursday, February 23rd at 1801 Northeast 6th Street. And this is at 12 p.m., Emma Lou Olson Civic Center. And we're just really excited to have you on board at Florida Medical Center. I mean, it's awesome to have you. It's awesome working with you. And thank you for everything that you do to help the community.
Thank you for the invitation, and it is very important for people to realize if you have any risk factors for heart disease. As I said, if you do like hypertension, if you smoke, if you have diabetes, if you're overweight, if you have sleep apnea, then you should tell your doctor and ask for a referral to be seen by a cardiologist.
Thank you, Dr. Galindez.
You're welcome.
We'll be back.
Hi, my name is Dr. Rahul Agarwal. I'm an interventional cardiologist in Jupiter, Florida. I did my medical school at the University of Florida and my internship and residency at the same program. I did my chief residency also at Shands, and then did my cardiology and interventional cardiology at Wake Forest University in Winston-Salem, North Carolina. I specialize in general cardiology, interventional cardiology, and nuclear cardiology. Even though I'm an interventional cardiologist, the majority of my practice involves general cardiology. General cardiology is a pretty broad spectrum in that it involves rhythm problems such as atrial fibrillation, heart disease such as coronary artery disease, congenital heart disease, high blood pressure, and cholesterol problems. I do procedures such as cardioversions, which involve trying to convert the patient back to a normal rhythm if they have an arrhythmia. I also deal with plumbing problems such as the coronary arteries, which if they're blocked, I can do angioplasty and stents, which involves balloons that open up the arteries. And these stents act as scaffolds that keep these arteries open. I really do believe in preventive medicine, and one of the areas that I really focus on is diet. One can really get caught up on the pills aspect and the exercise. And diet we talk about a lot, but unless one really has some guidance as to where to go with diet, it can be quite difficult. So I do give my patients homework in terms of books or movies that they can rent or obtain so that they can get educated. Our cardiology office is located in the Abacoa area of Jupiter, Florida, conveniently located between 2 of the local hospitals. We provide echocardiography, stress testing, ultra monitoring, and general cardiology office visits. We really pride our practice in its staff, who are very courteous and professional. We believe that under our care, you'll feel the same way too.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
Good evening, everyone. My name is Patty Villa, and I'm filling in for Dave DiPino, who's off this evening. Tonight, in our second half hour, we have Dr. Abdullah, who's medical director at North Shore Medical Center. Good evening, Dr. Abdullah.
Hi, Patty. How are you? Thank you for having me on the show today.
Oh, thank you for joining us this evening. I'm really excited to have you on. I know that we've been talking about some good news, some new news that's taking place at North Shore Medical Center. So I want you to tell the audience and our listeners what is going on, the latest and greatest at North Shore Medical Center.
So at North Shore, we will be obtaining something called the Da Vinci surgical robot system. And the robotic system is a tool that surgeons can use to allow you to do surgeries faster and more precisely. And I know that we use the term robot. However, it is a tool that the surgeons control to basically remove the target, or whether it's a cancer or a mass or the gallbladder in the case of having problems with gallbladders. And it basically allows you to remove those things more effectively and more precisely.
And I'm really excited that you're bringing that up and that you made that statement, because walking around through the different hospitals and talking to the different people that I do, some people have even asked me, is it a robot that does the surgery? So could you be a little bit more, give us a little bit more clarity so people understand? Because that's one of the issues that I have found is that people think it's an actual robot that's doing the surgery. And actually, I had Dr. Bayron on from Florida Medical Center that says a lot of people ask him that question as well. So what can you tell people to make them feel comfortable?
So in general, the robot, I know at times it can sound scary that you go into your surgeon's office and they say, oh, they're going to do it robotically. And it is a amazing tool that the surgeon controls. And so it is a machine that has arms. However, those arms are at all times controlled by the surgeon. It is never that, it's not like you push a button and you say, go do this surgery. That is not the case. What it is it's a piece of technology or a machine that allows us to have a better camera to visualize the area, to have more precise instruments, very much similar to our fingers and our hands when we're actually doing the dissection. However, we don't have to make a very large incision on your abdomen. We can do it through very small incisions, similar to laparoscopic surgery, which you may have or may have not heard of. It's basically doing surgery through small little keyholes in the abdomen. However, when you add the robot to the surgery, you're able to do that same keyhole surgery, but extremely precisely, very precisely and very, very detailed. And at all times, the surgeon or your doctor is in control of the robot. And I like to say that it's more of a tool that we use, not a robot. The name of calling it a robot is sort of more of a just a term that we're using, but it's really just another instrument that we're using in the operating room to do the surgery.
So, Dr. Abdullah, when a patient comes and sees you and you determine that person has to do surgery, how will you determine whether you use the robot or not?
So it depends. It is a very it is an evaluation that each physician performs. So depending on your history, if you have a history of multiple abdominal surgeries, then you may not be eligible for the robot. It depends on the situation. It also depends on the target surgery. meaning if you're doing surgery for the intestine, yeah, you can use the robot. If you're doing surgery on the pancreas, at times we can use the robot, but not all the time. And so it really depends on your history as the patient, if you've had a lot of surgeries in the past, and it also depends on what type of surgery we're planning.
And I know we're working on a couple of articles together that we're going to be, sending out so the community knows exactly what the robot is, and also to be informed, and also to learn about you and your leadership at North Shore Medical Center. One of the questions that I found interesting is, can a patient, and that I want the community to listen to, is, can a patient be discharged on the same day that they have the surgery?
So that's actually one of the greatest benefits of working with the robot. In the past, surgeries that make you have to stay in the hospital for multiple days, 2 days, 3 days, even a week sometimes, that hospitalization, that time that you end up having to stay in the hospital, gets significantly reduced. And at times, depending on the surgery, you potentially could go home the same day. So, for example, if it's a gallbladder surgery or a hernia surgery, most of the time patients are discharged on the same day. They get to go home, be with their families. There's less time that is needed to stay in the hospital. Whereas if the surgery was done in another manner, you may have to stay in the hospital for 2 days or 3 days, but it gets significantly reduced. Similarly, with intestinal surgery, typically someone that has an open surgery where you have to make a big incision on the stomach, they tend to have to go home 7 days later, at least 5 days to 7 days later. However, with the robot, you can minimize that and potentially go home in 2 days. So it's it's a significant reduction in the amount of time you end up spending in the hospital. But there are actually other benefits as well. And the other benefits include less pain. Most of the time when you make the smaller incisions and you do and when you use the robot, the patients end up having much less pain. And so that's part of one of the factors that allows you to get home faster, because you are in a significant amount of less pain.
And what does this mean? I know that you played an instrumental part, as well as the A team at North Shore Medical Center, especially our CEO, Manny Linares, helping bring the robot to North Shore. What does this mean for the community and the surrounding people that we have that come to and visit our hospital?
Well, I think that it's an amazing opportunity for the community surrounding the hospital, as well as other people from other areas that may come to the hospital. Again, most people, they're part of their daily life is being with their family, and if they have responsibilities to take care of, or if they have to, they're working, their goals are to basically get home faster. And the robot, the Da Vinci robotic system, allows that. It basically allows you to get home faster and get back to your normal routine faster. Of course, there's a lot of there's a few smaller details that each person is different, and so each person is has a unique situation, and so you should always check with your doctor regarding getting back to work and regarding getting back to your daily lifestyle. However, in general, that's one of the best benefits of this system and utilizing this new technology, in that it helps you just get back to your family and get back to your daily routine faster. And I think that's how it will benefit the community.
And what are the most, you've been at North Shore for quite a while now, and we're really lucky to have you in our community. What has been some of the interesting cases that you've worked on? Because when, I was reading through the articles that we're working on together, and I'm a big person that likes and loves quotes. And I read a quote actually that you had in the article several times, and it says, "Cancer changes people. It sculpts us into someone who understands more deeply, hurts more often, appreciates more quickly, cries more easily, hopes more desperately, loves more openly, and lives more passionately. When you, a family member, or a close friend has been diagnosed with cancer, what does this statement mean to you?"
So, again, so I'm a fellowship trained surgical oncologist. So basically that means that I'm a surgeon, and then I had extra training to become a cancer surgeon. And I think one of the most important things that I took away from my fellowship is how cancer affects people. And it's actually one of the things that I feel that has affected me the most. Each time that I come in contact and I meet a patient and I meet their family, it really is learning about that patient and learning about that family, and learning about how the cancer is going to affect their lifestyle. And that quote, it really touches my heart.
Yes.
In that it is most of the cancer patients, when they come out of their treatment, because treating a cancer is not, a snap of a finger. It's not, today I have cancer, tomorrow I get treatment, and then the next day I'm better. Cancer treatment is really a lifestyle approach. And that quote really resonates with me, because I find that most cancer patients, they actually identify with that quote. It really does make you, it makes you hurt more deeply. It makes you understand things more, you're more understanding. You love more passionately. You basically cry. You cry more.
It's like you understand life more, and you understand that life is precious.
Exactly, and it actually gives you a value to life. Not that the patients didn't have a value before, but it really does make you prioritize your the things in your life. And so getting back to what you were directly asking,
Yes.
You were asking me also what special or what. I'm sorry.
No, right. You've seen so many people, and you've helped so many people in our community. But what case has been maybe perhaps the one that has touched your life the most?
So I deal with a lot of different types of cancers, but I also deal with other types of surgeries as well, including benign surgeries or non-cancerous surgeries. But again, the surgeries that really affect me is when I get to meet the family and meet everybody and help them get through the process. Because, like I said, cancer, it's a lifestyle change. It becomes always a thought in the back of your mind. But I feel that I really get to help the patients conquer that. And most people, when they hear that they have cancer, they think it's a death sentence. And it's not true. That's not the case. There are certain cancers that we can cure. There are other cancers that it might be something you have to deal with, but it won't change your lifespan. And then there's other cancers that, yes, it may change your lifespan. And however, dealing with the cancer and dealing with the hurdles that come about in the treatment is what I find that makes or touches me the most. And so there's actually been, I would say, a lot of different patients that stand out in my mind. And honestly, I remember their names, and I remember the details, and I remember dealing with their family and dealing with their husband and telling their family that, the little details that are going to come about next. And those little details that's how I feel I get to make the most difference in their lives, because those details, the fact that they feel become comfortable with the fact that I'm able to help predict and tell them, well, now you're going to go through this symptom. It's probably going to start in the next few weeks. These are the new hurdles that you're going to start dealing with. And I think that that's how I feel most rewarded, by helping them get through this.
And Dr. Abdullah, talk to us about the team approach that takes place at North Shore Medical Center and all the doctors that you work with there on your team.
Okay. So specifically when we deal with cancers, it's important to have a team approach. And when I say a team approach, there's a lot of different physicians that are involved in cancer care. There are medical oncologists, which are doctors that give chemotherapy. There are surgical oncologists, the doctors that do surgery, which that's what I do.
Right.
And then there's radiation oncologists, the doctors that give radiation. Not all cancers will need to have radiation and chemo or even surgery. And so that's why it's important to have a team approach, so that it can each patient can be evaluated in a completely open forum where all details of their care is discussed. And so that is actually what we're doing at North Shore. We have a multidisciplinary tumor board, which basically means that there are radiation oncologists, medical oncologists, surgical oncologists that attend. In addition, we have other types of medical professionals that assist and that contribute to each patient. So, for example, there will be nutritional aspects that need to be addressed. So the nutritionalist will be there. Or if there's speech therapy issues in certain cancers of the oral cavity, speech therapy will be there. If the surgery is going to cause a physical dysfunction, then there's a physical therapy department that is present. And that's part of having this multidisciplinary team approach, making sure that you are anticipating all of the needs that the patients have and knowing beforehand and providing that support. And I think that that's what we are focusing on, and that's what we're doing.
And, I've gotten to know you on a professional as well as a personal level. And I'm just very happy that you are in our community, serving our community. And I know that you could be anywhere in this country. Why did you decide to come to North Shore and stay at North Shore?
Well, originally I'm from Canada, but I sort of grew up in this area. And so after leaving Canada, this was a while ago, I actually moved here when I was in elementary school. And so I grew up in the South Florida area, and I did leave for my training, where my surgical training was done in another state. However, my goals were always to come back to this community and really help the community. And I feel like I'm doing that here at North Shore.
And you are. You definitely are. We are so very, very, very lucky to have you. I've seen the way you've helped people. I've seen the way that you work with people. I personally enjoy working with you because we get to tell the stories so the community is informed. And, I think it's interesting, the past that you have, that, you were a journalist for a while. You were working at the Sun Sentinel, and you decided to go to medical school and become a doctor. And the name of the show is Doctors Are People Too. So what made you make that transition from journalism to being a doctor?
Well, I still have a great interest in journalism. I still do enjoy. I did work for Sun Sentinel at one point. I think that I always had a goal of being in the medical profession, and then I encountered journalism, and that was another interest. I don't think I actually made a transition where I was on track to be a journalist and then, made a 180-degree turn or a 90-degree turnaround and then decided to do medicine. I always had that idea. I wanted to do medicine. But journalism was just an additional interest of mine, and specifically when I was at Sun Sentinel, some of the department I worked at was the medical/science related stories that would end up that would be my focus.
Right.
However, I still have that interest. It's something that I haven't had time to develop since I elected to go into medicine and surgery and just going through the training, and then now with being a surgeon, I'm not able to dedicate much time to journalism. However, it still is an interest, and I do enjoy it.
No, and I'm glad, and I'm excited about the articles that we're working on to inform the community of the latest of what's happening at North Shore regarding the robotic surgery. What is it that you like to do for fun?
So my biggest interest is traveling, which I don't necessarily get to do it every day, but I love traveling, and so that is what I would say is what I love doing for fun.
And what are the last 3 places that you visited that you've enjoyed?
Well, my last trip was actually to Vietnam, Cambodia, and Thailand, and so it was a 2-week trip to Southeast Asia, and it was amazing. I really enjoyed Vietnam and Cambodia because of their history, and just visiting. There's a lot of ancient temples that are there, especially in Cambodia. I was blown away by the temple. It's called the Angkor Wat. It was so beautiful. And so Thailand was amazing as well. And so that trip was one of my most recent trip, but it was a very memorable trip.
Very memorable trip. No, and those places are definitely on my list to visit as well, because I, like you, love to travel, and I you know that because we've talked about that. We're coming to an end to the show. We only have a few more minutes, and I want to circle back to how we started the show regarding the robotic surgery. What is it that you want to tell the listeners and the viewers if they're a little bit nervous about going into your office or another doctor's office and having that doctor say that they are going to perform and use a robot? What are the words of calm and wisdom that you would give the patient?
So I would say to you that to a patient to make sure that they're choosing the right doctor, meaning someone that has had experience, that has had a lot of experience with the robot. However, I would say that the robot is a fairly new technology. It's an excellent technology and an excellent piece of equipment that the surgeons are able to use. And if your doctor is recommending it, I know that a lot of times it's foreign to the patient. They don't necessarily understand all of the details. But ask questions. That, I think, is the most important thing about obtaining treatment, is to be informed and ask as many questions as you need to ask to understand what is going to happen to you. I would say that most surgeons and most physicians that use the robot tend to be fairly well trained. They have to go through a rigorous process to get to the point where they are using the robot as well. And so if they're recommending the robot, I would have confidence that they potentially are very well trained, but ask as many questions as you need to ask to feel comfortable.
And what else would you like to say about what happens at North Shore? Because we always have so much going on at North Shore Medical Center. We have a lot of good people that work there. Like you said, we have the team approach. What is it that you would like the community and the public to know about North Shore Medical Center and the leadership team that is led actually by our CEO, Manny Linares?
I would say that North Shore is an amazing place. There's not a day that you will walk through the hallways, and if you look like you're confused or you don't know where you're going, There will be multiple people that will stop you and ask you, where are you trying to get to? There will always be someone saying hi to you in the hallways. There will always be someone that can easily give you directions somewhere. And I think that is part of what Manny Linares has provided. He provides a very open, very joyful place for everybody to work. And so it shines when patients are just walking in the hallway. I think that they feel comfortable because there's always someone that is, oh, do you need any help? Well, we can direct you where you need to go. And that's one of the things that I find most comforting in the hospital as well.
Yes, I do too, and I agree with you 100%. Dr. Abdullah, is there anything else that you would like to say that I didn't ask you this evening?
Well, I just want to say thank you so much for allowing me to come on the show.
You're welcome.
I am always available for the patients when they are referred to me. Basically, I'm a cancer surgeon, but I also do general surgery as well.
Thank you, Dr. Abdullah. And Dr. Abdullah is at North Shore Medical Center in Miami. And I just want to thank you for being this evening on with me at the show. I'm so happy you accepted the invitation. I was excited to talk to you about the robotic surgery that came to North Shore, that's at North Shore, where our community and people from beyond can benefit from. And thank you for your leadership. Good night, Dr. Abdullah.
Thank you so much, Patty.
Thank you.
Good night.
Thank you for listening and watching Doctors Are People Too with David DiPino. Join us next week for more in-depth views on what doctors are all about and how they spend their free time. All shows can be seen on amp2.tv. And if you have questions you want answered on the air, call 866-224-5422 and leave a message that can be read on the air. The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors.